But the next phase of how this tissue repairs and recovers and you rehabilitate is now being controllable. So get the compression on there, get the ice on there. So if you read those specifically, if you really need to take something because it's that sore, by all means take a painkiller if you need to. But if you can get through the first 48, 72 hours, chances are you probably don't need to take a painkiller.
And so it's very anti-inflammatories.
Yeah, no, they're not Thursdays. They're a quick fix. And look, when you're that kind of pain and you're on chronic inflammation and it's the only thing that gives you relief and you can get to your day, I get it. I'm not going to judge you on that. But in terms of injury repair and to get the best response out of your body and the best repair process, stay away from anti-inflammatories. Also, the effect that they have on your kidneys and your liver. If you've got any issues there, you're not going to really anti. So initially, your focus is on trying to get the inflammation down, try to calm that area down. You may then need to help with some remodeling in terms of the tissue that might have got damaged. So if there are some tears in the fiber, some gentle massage, some gentle soft tissue work, using some physio modalities, Matt, would certainly help that speed up that process a little bit better, which you're healing on the track a little bit better. Some gentle stretching and start getting a little bit of normal function and movement back into that tissue is part of that progression. Consistently, that inflammation should be coming down and you should start feeling a little bit better, range a little bit better, less tenderness and sensitivity in the tissue. Also within that phase, you should be addressing the mechanical component and the neurological input. The sooner we can get better neurological input to that tissue, the quicker it's going to heal as well.
How do you do this?
So from a chiropractic perspective, that's trying to identify where the breakdown in that communication is coming from. Most of the time, it's as the nerve exits the spine, very close to the joint, very close to the disc. If there's any kind of dysfunctional disturbance in that joint or the disc, it's going to have an effect on the transmission of information in that nerve. So that is most obvious place to go clear out first. That doesn't mean that there isn't disturbance further on that nerve. So there could be some scar tissue somewhere. There could be a previous injury that's causing a disturbance on that nerve.
If there are previous injuries, can you pick it up, heal it?
Addressing those, freeing up where there's scar tissue or restriction of the fascia or whatever it is that may be causing a disturbance on that nerve. The analogy that I use, and it resonates quite nicely, is that it's a bit like if you were trying to read something. In the corner of the room, there's a light flicker, and you just can't focus on what you're reading. That's what's happening to that nerve. So by all means, take an MRI, take an X-ray scan, go and do an ultrasound. You're not going to see a physiological, pathological change to the nerve or damage occurring on the nerve. It's a physiological disturbance on the nerve that is distracting the quality of information that's going on that nerve. So imagine it like a superhighway, okay? And that should be crystal clear, clean, smooth, no potholes. Yeah, that's it. That nerve should be able to send that information at lightning pace straight down that superhighway, straight to its receptor site. Now, every time there's a pothole or an exit or a bit of a dip in the rip, that slows down the transmission of that information to that receptor site. Literally every nerve in your body has something along those lines going on.